You should have both.
Great. Welcome everyone back to the House Healthcare Committee on Friday, March 17th. We have our fabulous legislative council with here this morning. Who's going to go over a couple of bills with us. The first one we're going to look at is H414. This is an act relating to unused drug repository program. It is on our webpage, and Jen's going to walk us through some of the amendments we made, or she made for us based on our discussion yesterday.
Great, thank you. Good morning. Jen Carby, Legislative Counsel. Do you want me to put the language up on the screen?
That'd be great, thank you.
Okay. Well prepared this time. All right, so we are looking at a strike all amendment to H414, which is an act relating to establishing an unused drug repository for Vermont. And after we did the walkthrough yesterday, I went off and worked with Brendan Atwood from the Health Department and Devin Green. Those were your two witnesses yesterday, and on some of the amendments that you had, or that we had talked about. So the first is in this subchapter, creating the unused drug repository program. I had mentioned that Nolan from Joint Fiscal wanted some clarification about the funding. So this says, the Agency of Human Services may contract or enter into agreements with qualified entities as needed to create and administer an unused drug repository program for the collection and distribution of unused drugs in Vermont to the extent that funds are appropriated or otherwise made available for this purpose. So this is kicking it back to the legislature to decide whether to fund it, whether and when and how much to fund, but it's at least getting the process started with rulemaking.
Great.
And you'll see later on is the report as part of budget adjustment, but that's at the end. So I did not make any changes in the content of section 4672, which is the AHS rulemaking language, but I did add a new section based on the committee discussion and the requests yesterday around limitations on liability. And so this says, and we use some of the language from Georgia's statute, Georgia, as Brendan told you yesterday, is one of the two states with a pretty robust program that is administered through that state. And so we used some of their language, made some changes that seemed appropriate for Vermont. So this would say, except in cases of bad faith, gross negligence, intentional misconduct, or non-compliance with the rules adopted pursuant to section 4672, that previous section of this chapter, the following persons shall not be subject to civil or criminal liability or professional disciplinary action for participating in or otherwise complying with the program established by this chapter or rules adopted pursuant to this, subchapter or rules adopted pursuant to this subchapter. And that list is a person who donates or gives drugs to an eligible recipient, including a drug manufacturer, wholesaler, reverse distributor pharmacy, third-party logistics provider, governmental entity, hospital or other healthcare facility as defined in, and we're cross-referencing our certificate of need statutes because that's a broad definition, or long-term care facility licensed under our long-term care licensing statutes. An eligible recipient as defined by the agency by rule based on that criteria that you had given them in 4672. A healthcare provider as defined in one of our general healthcare administration statutes who prescribes or dispenses a donated drug. An intermediary that helps administer the program by facilitating the donation or transfer of drugs to eligible recipients. A manager or repackager of a donated drug. And any employee, volunteer, trainee, or other staff of any person listed in subdivisions 1 through 5. So pause there if you want. So that's the immunity provision. It's pretty broad, but it's really about providing immunity for participation in the program as long as it's not, intentional misconduct, gross negligence, things that we typically do not excuse people for with immunity.
So those words, bad faith, gross negligence, intentional misconduct, or noncompliance with the rules adopted pursuant to section. So are those words defined?
Some of these are really legal standards.
Okay.
For the most part, they are. Gross negligence may actually be defined, but is fairly broad. These are things that would be alleged and then be proven in the course of litigation.
Okay. Any other questions on this section?
I mean, I would just, if, God forbid, somebody, this contractor who takes these drugs, rebottles, injects them, mixes up drugs of some kind and somebody has a bad reaction, say somebody, they will have the ability to sue, to be,
If what was done at that entity, facility, constitutes gross negligence. So if they, if they followed all of the steps that they're supposed to follow and somebody had a reaction that was not foreseeable, something like that,
It wouldn't be.
that wouldn't, if there was nothing that the facility did wrong, then they would not be liable. So if the healthcare provider prescribed a drug that somebody had a known allergy to, or something that was, sort of outside the standard of care, there could be liability for the provider there, but it wouldn't be the facility that was responsible.
okay.
And just to clarify, and correct me if I'm wrong, Jen, anyone can sue.
Yeah.
It's just a matter of, can they be liable?
Will they win, right?
Will they win, right, yes.
Well, but we're funding the program. Who gets sued? Can we be sued as a state?
No, we have sovereign immunity. I mean, so we'd say, we declare to be.
Okay, I mean, all right.
But this does say, it gives.
If you folks see it as good, you're the legal mind, that's fine. I just bring it up as, I mean, two pills look the same. You could,
Right.
they get in the wrong thing, somebody takes it.
Right, that's probably gross negligence. I mean,
But
that's,
it would be different that a hospital made a mistake, the pills make.
Right, or a
look the same.
pharmacy.
But we're funding the program. That just.
That's
I
what
bring
you're
it up.
wondering, what's our liability, because we're funding it, and then what I'm hearing you say is we're
No,
protected.
right, I think we're
it's not a deal
protected, and
breaker for me. I
it's,
just.
governmental entities are also listed under there for.
Yeah.
Make a federal case out of it.
Alan?
Yeah, on eligible recipients, can you give me an example of a third-party logistic provider?
So and Brendan may have other thoughts on this as well. I think a third-party logistics provider could be the transportation, whoever is actually transporting the drugs from Iowa or Georgia or wherever it is here.
And you know what, Brendan just popped on. Can you just tell us you do or don't support this or provide any comments?
Good morning, Madam Chair. Brendan Atwood, Department of Health. We do support this language and appreciate Jen's work on it.
Great, thank you.
Thank you.
All right. And then in would be section 2, I have an update on the rulemaking process. And I've used the word report here because it helps us in Ledge Council track what we are expecting you to get information on for next year, but it doesn't actually create a report requirement per se. And so this directs the Agency of Human Services to provide an update on the status of rulemaking for the administration of the Unused Drug Repository Program as part of the agency's fiscal year 2024 budget adjustment presentation. So I'm calling that, for purposes of our tracking report, just so that it'll be on your list of things you're expecting to hear next year. And then the effective date would still be July 1st.
Leslie?
So I was wondering about when you said, and referred to that in the creation of program, to the extent funds are appropriated, and then referencing that section down at the bottom, or is that not necessary? Because that that seems like a little bit hanging to me. I'm not sure what that.
Which part?
In creation of program, to the extent that funds are appropriated, otherwise made available for this purpose, like when? So it's in the beginning, it's not connected to the BAA, but in the end it is.
Well,
So
it
I was
isn't
wondering as-
specifically. I mean, so you're going to get an update on rulemaking in BAA. The Agency of Human Services may be ready to ask for money at that point. They may not. They may ask for it as part of the FY25 budget. They may find other funding sources that.
So would it be like as stated in section 2?
No, because section 2 is a one-time update on rulemaking, and
Okay.
the rest of this is going into statute to give ongoing authority to contract for the program to the extent funds are appropriated. So we can't require that funds be appropriated
In the future.
in the future.
Yep.
And so this is reflecting that the agency does not have the authority to contract for the program if they don't have the funding for it.
And we, I asked the question yesterday, Brendan, who's still here, that, you know, the full understanding that if this legislation gets passed and they embark on rulemaking and we don't fund it, like that has to be an understanding. And I just want to say again, Brendan, from the Department of Health perspective, that's the understanding of what we're doing here.
That's correct, Madam Chair. And I think this language allows for some flexibility for alternative sources of funding should it not be appropriated by the legislature as well.
Great.
Oh,
Right, so that's why we have this, or otherwise made available for this purpose. If the Agency of Human Services is able to secure outside funding, you are still authorizing them to go forward and create this program.
Oh, I
So you're
get it.
blessing the policy. You're not making guarantees on the funding.
The funding. Okay.
think of Act 48 of 2011.
Okay. Any other discussion? Art?
Well, I have to say, the amendment's fine, right? But I have some real heartburn with who gets this stuff.
Who gets the drugs?
Yeah, no, page 2, item 4, in the list of people. I don't understand why we don't make this available to everyone. I don't get, if we're going to repackage this stuff, which I totally agree with everything. We've got to repackage it. Why doesn't that get put into the system so that anybody that has to get that drug can get that drug regardless of income, insurance, or anything? It seems to me that because you could possibly have, if you restricted these folks, you could have a lot of stuff that's never used. It seems to me that you would want to have this available to everybody.
It doesn't restrict eligibility. It directs the agency to include patient eligibility as part of their rules, but it gives priority to patients with financial limitations.
Could we word that differently somehow to make that clear? Could it be, I don't know how.
Can you scroll back a little, just up a little, honey? I want to read like the beginning of it because I want to see how it starts, like here.
You want me to go back
Yes.
down now?
Yeah, thank you. I just want to.
No, that's fine.
I'm
There's
listening.
nothing there that should trigger it.
And I guess, can I say something?
Yes.
Yeah, because I'm like listening to you and trying to think, like how could we satisfy your concern without weakening what we're doing? And I wonder if it's something like, you went down too far. I wanted to see 2 and 3. I'm sorry.
Oh, okay.
Because it says like, it talks about eligibility here with priority given.
Okay.
Maybe it's, I don't know, if adding a simple phrase like, patient eligibility to receive drugs from the program, with priority given. I don't know about the wording, but
If all patients are eligible,
Right, like,
with
yes.
priority given, it would at least
something like that is what I'm saying.
look like, because, okay, now that you say it's with priority to
Yeah.
these folks, I get that. That makes it clearer to me, but it would be good to me to wordsmith it a little bit so that it's understood that, the hospital has a great supply of X drug that goes into a thing and a millionaire needs to use it. He can get those drugs, not free, but at a discount or however.
Okay, so hold on. Are we sticking, hold on. Are we sticking to the same thing? Go, Alan.
But I think it also said free. So
Does it say free in here?
it did on the.
I think that was part of the testimony about how the program is envisioned,
So.
that it would be
If you want
free.
an insurance.
but it does not specify in the directive
It doesn't.
But it has to be.
that it has to be free.
So does that make? Okay. Leslie?
So would it help to say all patients are eligible with priority given?
Yeah, something like that.
Alyssa?
I just wanted to point out, I love that. All patients are eligible. I'm thinking about what if there is a drug that is coming close to expiration and they have a large quantity of it, and yet there's they don't have enough people who are eligible.
That's exactly what I was.
So
I think it's semantics, right? I think the language that's in here, correct me if I'm wrong, Jen, is stating patients are It would be all patients with priority given to.
It does not specify all patients or a subset of patients. It just identifies which patients would get priority as part of the rulemaking that is determining eligibility. So there will be considerably more language in the rules on eligibility. We can certainly put something in. I think it gets a little bit confusing when you say all patients, what that means, whether you're talking about Vermont patients, whether you're talking about people anywhere in the country. What if they're, live in a neighboring state but receive care here? So I think I get a little bit worried about trying to address that in your directive to the agency without, that might lock them into something that you didn't need to lock them into.
So Brendan, can you pop on? Thank you.
You're welcome.
So does the conversation we have here that we would like it to be available to Vermont, we want it to be available with priority given to, that's our intent without us having to change this language?
Yeah, absolutely.
Is that how you viewed the language? I apologize.
No, sorry for jumping in. That is consistent with our understanding of this as well. We would want this to be broadly available, and the language priority was intentional to do as you suggest, which would kind of put these folks to the front of the line. But we wouldn't want to restrict anybody from accessing this program if the medication was available to help them.
You certainly could put some kind of intent statement in. I know there's been some requests from LCAR to have a greater understanding of legislative intent when they're trying to evaluate whether.
So could we do an intent in the beginning? Would that be the best?
Like a sentence.
Put it, Jen?
Like in the creation of the program?
Yeah.
So if that was the case, could we add something like after unused drugs in Vermont, where the yellow begins now, that says like for the collection and distribution of unused drugs in Vermont to all people in order to reduce waste, to the, you know what I mean? So it's just a phrase that clarifies our intent without saying it's the intent, unless you think it needs to say it is the intent of the General Assembly.
I think it's probably better to say it is the intent,
Okay.
because if you create a program that has to be a certain way, I'm going to take the language down for a minute.
Okay.
Sure. Through it and potentially make changes to it.
1 second. We got Topper first. Are you good? Okay, Alan?
Okay, do you have to use all?
No, I don't think we want to use all.
No.
Right. So we're gonna give Jen a minute to process what we're saying.
Patience.
Patience.
We'll all take a breath together.
I don't have a lot of patience.
No.
So,
I have a lot of patience
Not
and a
all
lot of
patience.
patience.
Yeah.
so let's give her a minute. Okay. Let's go.
Can I just sort of
Okay.
sing and think about where something might go?
I just think it's the implication of whether it's a program for only poor people, that whole list, or is it a program for all Vermonters? And in a way, I think your point is well taken, that it's for everybody.
Right.
So that is part of the intent. That it is, so that I don't want people to sort of generalize that it's only for poor people necessarily. If that makes sense.
Yep.
I think as it stands, it does that. And
Okay. But I think this piece of it, for the folks that are going to administer it, needs a lot of work. I do, because I don't know. I'm trying to visualize how this stuff, all these repackaged things, you have the new stuff going in, you have, the pharmacists are sending, the suppliers are sending stuff, and then you have this other stuff that's used, says used. Okay.
It's not used. It hasn't been used, but it's been
repackaged. Been
Right.
repackaged.
repurposed.
Whatever you want to call it.
Right.
How does it get into the stream, or does it? If I go in, I take a certain drug, X drug. Somebody else somewhere takes X drugs, and I don't know, they pass away and the drug is, and their friends put it in the system. Okay. I get theirs. Do I pay less for that, or do I pay
So this is all so this is not our purview to decide.
Right.
It is all, and that is why we allow rulemaking.
Okay.
That's what the rules
That's
are gonna
what
do.
rulemaking.
All right, that clarifies it for me.
Yes, so we're just setting forth the policy directive.
Thank you.
They will do the rulemaking. There's other states that are doing it, so I'm sure they'll look at other states. And then they'll report back to us.
Got it.
That helps.
So I have potential, let me just put something up and we can see what you think. Because I'm sort of back to putting it in with the actual language. To have it say something like patient eligibility to receive drugs from the program, which shall be available to all patients with priority given to patients who meet one or more of the following
That's
criteria.
wonderful.
Everyone good with that? I think I just turned to Department of
Maybe we
Health.
say available to any patient,
To any patient.
Yeah,
comma,
that's
with
better.
priority given.
Brendan?
Yep, that looks great. Thank you.
Tucker?
Now I have a question.
Okay.
Is that a patient that that is in Vermont, or does it mean any patient
I think
that's a Vermont resident?
So at the moment, it does not specify where the patient is or,
Passes through.
so I think that would be a question for the department of how they envision this working, whether there would be a residency requirement, in which case we might want to specify that.
I
Brendan?
think it would be our preference that there not be a residency requirement at this point. I think it just ties our hands a little bit too much. And, we can certainly consider that during the rulemaking process. But part of the value in, this way that we're pursuing this is that we'll be able to work with other states as well. And so we wouldn't want to limit participation in the program by residency, at least not in statute.
Okay, thank you. Leslie?
Do we get a chance, and I'm not really sure I understand the process of rulemaking very well. So we pass this, they make a whole lot of rules. I know it goes to LCAR. I know we'll get a report because that's the
The
last
update, yep.
thing, or not the report, but whatever.
Update, yep.
Yeah, update. Okay. Do we get to comment on that in order that they respond to, or is it a passive? We receive it in a passive way or?
So based on my understanding of the projected timeline for these rules, there's a good chance the rules will already have been adopted by the time you are getting that update, or will be very close to. So at that point, LCAR will have likely already weighed in. Their goal is to ensure that rules comply with statute, with legislative intent, do not exceed the authority given to the agency, certain criteria set out in statute. The chair will get a copy. The chair gets a copy. The chair of the committees of jurisdiction gets notified in a copy of the rule before it goes to LCAR. So I would say that is really the kind of the last opportunity to comment or to ask to request changes, because it's already pretty far through the process at that point. But Brendan has gone through a lot more active rulemaking than I have. So I don't know if he has other thoughts on the process.
No, I think that's right, Jen. I would just add that, of course, there's always a public comment period, and we're happy to meet with stakeholders directly or to facilitate them during our normal public comment period hearing.
So is there a way that we can know as we go through this process that the public comment period is open? Because a lot of things seem to fly by, in the summer, so how do I follow along or?
I'm looking at Brendan.
Yeah, the Secretary of State has a website that you can sign up for notifications, but I would be happy to provide the committee with an update when rulemaking has started formally, if that would be helpful.
And then maybe goes to public comment so we can follow along. That would be helpful.
Great, thank you.
Thanks, Brendan.
All right, any other changes? Discussion before we take a vote.
It's 1.3.
All right, Claire, you have a document? I'm just gonna do it this time.
Does someone need to make a motion?
And, yes,
I'll make a motion, that we pass draft number
2.1.
2.1 of H 414.
Second.
I'll get the next one ready.
Draft number 2, what is?
2.1 of H 414.
Again, for those watching us. We're scrambling here because our very confident clerk is not able to be with us today. Very competent clerk
And confident.
and competent.
I thought, but that works.
And the replacement is stymied by this form, so
Right.
that's.
All right, did we get a second?
We had 2
Several of them.
seconds.
Great.
Do we have 3/3? I'm kidding.
2/3 make a whole.
Don't you like the clerk to call the roll?
Oh, she filled in the names. That's awesome.
Yeah, I
Yes,
know.
please.
That's-
Please
I
call the
was
roll.
like excited. Representative Rebecca. Yes. Representative Black. Yes. Representative Chena.
Yes.
Representative Cordes. Representative Demar.
Yes.
Representative Farlise Rubio.
Yes.
Can't pronounce it the way Demar does. Representative Goldman.
Yes.
Representative Houghton.
Yes.
Representative McFawn.
Yes.
Representative Peterson.
Yes.
And Leslie will be the reporter of the bill.
I'm sending it.
Madam Speaker, I'd like to explain my vote on this.
Vote tally was 901.
Great, and Jen, you will send what needs to go to,
I am sending it to Claire, Representative Goldman, and to you.
okay, great.
And
Right.
this will not likely go to anywhere, right? It's not going to Ways and Means or Appropriate.
I will talk to Betsy Ann to see if it's gonna go to appropriations.
Okay. Yeah, I'd like to know just so from a timing.
No. There's nothing.
But it's not a no vote, it's, so you just do 901, yeah, you don't put it anywhere there, you just leave that out. Great, all right, so that is H414.
Thank you, Brendan.
Thank you very much for
Thank
being
you all.
here. We appreciate it, have a great weekend.
Thanks so much. You too.
And thank you, Jen.
All right, we're ready to move to 282?
Yes.
All right, this is the Psych Pack Compact. We have enough of those.
You're so prepared. Guess who's going to report it?
Yeah, it does.
Is that the title?
I've asked you about my reporting of it and how much of the process is important to include going in how far and blah, blah, blah.
That's great, yes.
Totally.
Yep, we'll totally talk.
All right, so,
I'm sorry, no, I emailed it to you and Claire.
Okay, thank you.
so shifting gears to 282, Psychological Interjurisdictional Compact. Jen, is gonna walk us through the updates.
Great. So we are looking at H282, as the chair said. It's an act relating to the Psychology Interjurisdictional Compact. I made some, other than the first page, some minor non-substantive changes throughout that I think improve readability or address grammatical issues that I saw. It is a compact, but I've noticed that at least some of the other states that have adopted it have also made some corrections in that way. And so I also uncapitalized some things because there was a lot of capitalization happening. I left some of it in, but tried to be a little bit more judicious in the options. So we start with recodification from where the bill was originally going. Bill, as introduced, had this going into 26 VSA Chapter 56. That there's actually already some stuff in that chapter. So we went with, I actually think this is a great place for it anyway, new subchapter 2, created a subchapter 1 for the existing provisions of the psychologist licensure chapter and made a new subchapter 2 for the compact. So that's consistent with how we've done at least other compacts that I have worked on. And then I put in, as we talked about yesterday, a first section that is specifically and affirmatively having the state enact and adopt the compact. So this would say that Vermont hereby enacts and adopts the Psychology Interjurisdictional Compact. The form, format, and text have been conformed to the conventions of the Vermont statutes annotated, and it is the intent of the General Assembly that this subchapter be interpreted as substantively the same as the Psychology Interjurisdictional Compact that is enacted by other compact party states. So I have highlighted where I have changed words. I have not highlighted where I have uncapitalized something or changed like added punctuation, because it starts to get a little harder to read. So,
6 pages.
yeah, so it's a pretty hefty compact. So one of the things that I did, and I can just go, if you're interested, I can tell you what I changed, but we do not typically in the statutes use IE, which is what had been on line 6 of page 2. So instead of saying IE, the provision of psychological services, I said, which is the provision of psychological services. And in the bill that originally, as introduced, it was all a big parenthetical. We don't typically use parentheticals in the statutes either. So I've just sort of revised the way this is worded a little bit to reflect more how we do things and also the name, the terminology that we would use. So instead of saying, i.e. the provision of psychological services using telecommunications, I said, which is the provision of psychological services using telecommunication technologies, which is the term that is used elsewhere in the compact. So it seemed more appropriate, and is what at least one other state has done. I didn't look at all of them, but New Jersey made a bunch of changes, so I was looking at theirs. Another thing that we do not typically do in the statutes that was throughout the compact is the phrase or the term and/or. So in many and other things have a slash through them. So they have client/patient throughout the compact. I went with what New Jersey also did, which is to say client and patient, just so it's not as confusing. I updated cross references. We are enacting this as a subchapter, so I changed chapter to subchapter and updated cross references to reflect the new placement of this in the existing psychology chapter. So again, on page 5 here, we went from client/patient to client or patient is the recipient of psychological services. And then instead of saying and or at the end of the list, I added or a combination of these. This is just the way we typically do our statutes. And we have the cross references again, so I highlighted those, and or became unauthorized persons or processes or both. I did highlight the use of a couple of commas here instead of parentheses. You tell me how much of this you do or do not want me to go through.
I was gonna say, do we care about the ors and the ands? And
No.
The grammar.
Trust you.
Grammatical correction. I'm trying to see if there's anything else.
I would request that we only see the changes that affect the policy or practices of the state, not technical.
So there is nothing, because it wouldn't be a compact. I mean, we would be
We would need, there's no.
blowing the compact at that point.
Oh, if we, yeah, exactly.
Just grammatical.
It's all grammatical, a couple of words missing, some of which were in the bill, or I'm in the model language as well. All right, let me take this down and I'll scroll through and see if there's anything without making you watch me scroll through. I don't think there's anything.
It's hypnotic and soothing.
Sorry?
I said it was hypnotic and soothing. Did you see? Or.
I don't know, I'd like to see a different color though.
So I will actually tell you the reason that there is only yellow is it's the only one that really you can print out and see.
I always wondered why everyone always used yellow.
Dark and
Here's
is,
the letters.
Yeah.
Read in fuchsia in the other room, you couldn't read it.
yeah.
Oh, okay. Well, that's good to know.
So for on the screen, the different colors works fine, but when somebody wants a printed copy,
Yeah.
it's hard. In case you were curious. Yep, these are all, I mean, they're all, those of you who've worked with me for a while know I'm a stickler for what's technical. These are truly technical
Yes, we trust you.
because if we made anything substantive, then we would not be actually joining the compact.
Leslie.
So this is just a reminder for me from the previous compacts. We can't change compact language, I understand that, but we need a 46-page bill to do what?
Enact the compact.
Yeah.
Enact the
I mean,
compact.
it has to be in our statutes.
Puts it in
Okay, so this
statute.
puts it in statute.
Right.
Yep.
Right. We just can't change.
Can't change.
All compacts have to have the same.
That allows
policy,
us to be implemented.
Yes.
Okay.
Yes.
How many people
This is how we
sleeping
join.
when this is presented?
Well, obviously, I slept through some.
Hey, we don't admit to that.
Anything
Wow.
else, you're all welcome to look at it. It's online. I did send it to OPR last night. So not a ton of time, but have not heard any
Right,
concerns so far.
and it's all technical, so.
My email before I announce that, but because I don't think Lauren is with us.
So let's talk about policy here and thoughts as we look to vote this out. Discussion?
How many states are part of this now? Do we? I know-
36.
Yeah.
Well, 30, you heard yesterday, 34 have, it is in effect in 34 states with 2 more in the 6-month waiting period between when a state enacts it and when it becomes effective. So
Neighboring
36.
states involved?
Think you-
Jen?
Yes, I think New Hampshire seems to be all over the compact.
Yeah. they
I know.
have
New
that.
Hampshire, Rhode Island, New Hampshire, and Rhode Island are 2.
I think
Okay.
Maine, which
New
isn't
York.
bordering, but I can actually tell you from their,
Of course, we'll tell telehealth.
SIPAC, yeah, so Maine, New Hampshire, Connecticut, and Rhode Island have all enacted it. Massachusetts and New York so far have not.
So Vermont's last in New England, huh?
Okay, gotcha.
Oh, Massachusetts and New York have not.
Well, yes, Massachusetts.
Not New England.
Oh, right.
Bordering states.
Okay.
And then, as you heard, Michigan and Rhode Island are in that waiting period. It looks like legislation has been enacted in New York, Massachusetts, and a few other states. as
Not enacted, but in.
Introduced. Legislation has been introduced. Yes, important distinction.
Art?
Does licensure work like the other compacts with this, Jen? And pardon me for not reading it all, but
No.
the licensure,
This one is different from your other compacts. I was
Okay.
not part of your other compacts, but I heard Lauren say, this one is different from other compacts I have worked on as well. So this one is more limited. There's a limited subset of Vermont licensed psychologists who would be eligible to participate in it
okay,
because of their educational level. And then there's the potential for just doing telepsychology or the potential for doing just temporary in-person practice in another state or both. And the fees go to the board that created
Right.
the legislation and another organization rather than to the compact states.
oh, okay, so it goes to that board and not to the compact.
That's
state.
that was the testimony from Lauren yesterday,
Okay.
that the money goes to the, I'm not gonna get the acronym right, but the ASPPB.
So probably there'll be no financial impact.
So that is what they were saying was that's a revenue loss to the state or lost, the lost opportunity for revenue to the state for providers from other states who might otherwise take a Vermont license or take our
Right,
telehealth registration or license. And there is the potential for fees. I don't actually know what the fees are, if they have specified what the fees are for the program, but there is language that talks about either requiring states to pay something or imposing fees on others to pay for the commission itself.
So it'll go across the hall, right?
yeah, no, I understand, I'm just trying to get a sense of what this does, in terms of money.
Right.
It doesn't sound like it does anything bad, I guess.
No, and I think the general philosophy here, and is like, we heard it 3 times yesterday from Ways and Means and Appropriations, that the policy outweighs, in this case, the fee loss. But at the same time, I know everyone, including OPR, is looking at how they are funded, right? Because they're
Right.
funded all by fees, and the way, at least in the healthcare system, things are moving,
That's right,
it's really changing.
Yeah.
And so we'll have to find a way to change with it.
yeah.
So, Brian, and then I think Leslie.
Nolan also has something to say.
Oh, no.
Maybe you can go first and then
No,
I'll.
I don't know why I called you Noah.
I was
Nolan.
just gonna say that the fee loss is estimated at about 17,800.
On this one?
Okay.
Okay, great.
Annually or total?
It's biannual.
Annual.
So-
I saw that.
So now I would like to make my point, knowing that there might be a loss in fees, but something to consider, and I don't know how you would even begin to estimate this, is that it may generate tax revenue because providers in Vermont are paying income tax in Vermont. And if, like, as a provider in Vermont, if I have a client going out of state now, I lose that client because unless I get a license in that state, which is like really complicated and tricky. So it would allow me to keep seeing that client. That benefits the patient, but that also maintains revenue for the state that I'm paying in income tax. So I'm just saying that there might be, it might balance out in the income tax we would have lost from patients leaving the state.
We just have no way of really.
Yeah, we don't know.
But that's a good point.
And they go into different funds, but.
Right.
Another distinction,
But
yes.
yes, but interesting point.
Yeah.
Leslie, did you have something?
Well, I just went to OPR because I'm curious to know how many people would fit into this category because it was only PhD psychologists, if I understand that right. And they're not even listed as a profession. Oh, I know it's gonna help me.
Doctors of psychology.
I can tell you, for the record, Noel Langland, joint fiscal office, talking to OPR, they felt that the number of out-of-state applicants was going to be 106.
106.
So out of state coming here, and then how many do we have
That's
here?
the amount that are currently buying Vermont license that would now be doing the compact.
Okay.
Could potentially be doing a compact.
That's why.
There is also the potential that they could go, if they wanted to provide telehealth services, they could use our newly to be implemented telehealth licensure, which might be more cost effective than some of the
So,
options.
I see this as, again, ensuring that we're increasing access to, people and allowing providers to move around, which is important too.
Our opportunity.
Any
I
other?
am interested that there are no psychologists listed as a,
They are though.
where, I mean, I
Called
can't,
something there because I know that there
we could
are.
look at it after, but I'm curious.
Yeah.
Well, I'll look now.
Yeah.
Yes, I mean, I think you just heard from one yesterday.
Yes, you've heard from.
Yeah, so I'm
There's
like-
not many in Vermont,
Yeah, that's what I was curious about and for sure.
Which is why it's great to have more.
right?
But there is no psychologist listed unless I'm doing it wrong, which is.
I think they're listed. I'm gonna look.
So I'm gonna let you all figure that out after.
Yeah. Here's the list.
So any further discussion? Are we ready to take a vote? Put it that way. All right, motion. Does anyone want to make a motion?
I'll move that we accept this language and bill.
H282 draft 1.1, I think, right? Jen?
Yes, I will clean it up. I don't know if you want to make it a 1.2. I'll make you a clean version.
Second? Okay, thanks.
Representative Rebecca.
Yes.
Representative Chena.
Yes.
Representative Cordis. Representative Demar.
Yes.
Representative Farlise Rubio.
Yes.
Representative Goldman.
Yes.
Representative Peterson.
Yes.
Representative Black. Yes. Representative McFawn.
Yes.
Representative Houghton.
Yes. And Daisy, do you still want to be the?
Unless someone else would like to.
No.
Yeah, I'd be happy.
Daisy. Thank you, Daisy.
Total 901.
Great, and this will go to Ways and Means, Daisy, so you have times and appropriations, so you'll have some time. Great. All right, thank you, Jen, very much for all your work. Have a fabulous weekend.
Thanks, you too.
Run while you can. I do want to say that, like, just to validate Leslie, is that when I look at the Secretary of State's professions list, there is no clear distinction of psychologists. I do see psychological examiners, I do
I believe that is because that's the regulatory or the licensing board. I think that is where you would look under.
Exactly, so it might be where we're looking,
But
that's the
there's
problem.
lots of different doctorate levels. You have to put.
Psychological examiners. Thank you.
And there's different kinds of licenses, and I think that's where, maybe we could just look at this more in the
Nolan,
future,
thank you.
Hope
Have a good weekend.
Showed up at the precisely right moment.
Katie, do you want to join us? All right, we are switching to our last bill of the day.
We can do this. We can do this in 30 minutes.
Can do it. This is the committee bill, suicide prevention. We had a draft yesterday, and at the end of the meeting, we tasked a couple of people to work together offline to come back with suggested language. So we have that, and we're going to have Katie walk through it.
Perfect. Good morning, Katie McLean, Office of Legislative Counsel. I like your hat, Representative McFawn. You're very festive.
Katie, my girl.
Where's your pots of gold?
Oh, by the wastebasket.
Oh, okay.
Can I just ask a quick question? Is the one on our webpage the most recent?
It is. I think I added, are you looking for the language that you asked for? I think I added it in the right place, but the
one I was talking about? Yeah, it's there.
It's there. Okay, great.
Oh, there it is.
Yep.
4.2. It's on page 2, line 12.
Okay, that's fine. So we're draft 4.2.
4.2, yeah.
Okay, great.
So I don't know if I said this, Katie McLean, Office of Legislative Counsel. We haven't made any changes to section 1. I don't know if you want to walk through it again or just let's walk right over it. Okay.
We can run through it.
Okay. Speed read. Okay. So chapter section 1 creates a new chapter entitled Preventing Death by Suicide. And then there's a new section added there, Director of Suicide Prevention, and this goes over the duties of that position. So the Department of Mental Health's Director of Suicide Prevention shall lead the state's suicide prevention efforts, intervention supports, and postvention efforts, and collaborate with communities and providers to reduce the number of suicide deaths and attempts in the state. The director shall promote and support statewide crisis and suicide prevention recommendations as outlined in the state's suicide platform, including the creation of a strategic plan and suicide prevention education protocol for all schools. The director shall expand partnerships, implementing innovative data-driven initiatives, coordinate suicide prevention programs across the state, and work to secure federal funding. Then section 2 is where we have some changes. So if you remember, this is sort of a few prongs. So the first prong is work that the Director of Suicide Prevention is doing with AHS and stakeholders, and the second prong is work that the Director of Suicide Prevention is doing with the Agency of Education and stakeholders. So under this first prong, have that on or before July 1, 2024, the Director of Suicide Prevention, in collaboration with AHS and stakeholders, shall develop and submit a statewide strategic plan pertaining to suicide prevention services, training, education, and postvention services to the House Committee on Healthcare and to Senate Health and Welfare. The statewide strategic plan shall identify goals, possible partners, and strategies for meeting clearly defined targets and the prevention of suicide. Key resources and gaps shall be identified, including sustainable 988 Lifeline funding, zero suicide program expansion, improved data collection and reporting to identify contributing causes, including social factors to inform prevention strategies and data-informed systems, and strategies for establishing and maintaining postvention services within communities, schools, and healthcare systems. Prior to the submission of this plan, the Director of Suicide Prevention is to submit quarterly progress updates on the development of the strategic plan to this committee and the Senate committee between July 1, 23 and April 1, 24. In the January 2024 progress update, the Director of Suicide Prevention shall include preliminary budget recommendations and a sustainable funding plan for the 988 Lifeline. And then we move to the second prong, the AOE work, that by January 15th of 2024, the Director of Suicide Prevention, in collaboration with AOE, and stakeholders shall develop and submit a model protocol for all schools regarding suicide prevention, education, and post-prevention services to this committee and to the Senate committee. I just want to scroll up. I had a thought while I think this should be
July.
That's correct. Yes, okay. I was thinking January 125, July 124. Okay. Section 3, this is a presentation. So on or before, we've changed the date to February 1, so it's 2 weeks earlier. The Department of Health, in collaboration with the Director of Suicide Prevention, shall present information to the two committees regarding the work accomplished by the state in accordance with CDC's Comprehensive Suicide Prevention Grant, including the results of the Complete Suicide Data Linkage Project. Prior to the presentation required by subsection A, the department shall submit the results of the Complete Suicide Data Linkage Project to the two committees as soon as they are available.
Great. Leslie?
Thank you for adding the language. But I was including social factors, and that really helps me, sort of point in that direction. And then Alyssa this morning sent me this form that they use in Colorado when there has been a suicide, which really goes in such depth, and it was so impressive. So I just hope that could be somehow included. I don't think anyone.
Well, it's not going to be included in.
No, I mean, included in their work, is all I'm saying, as informing their work as they move forward.
Well, he has indicated, Chris Allen, the Director of Suicide Prevention, has indicated that he will be looking to Colorado.
And he's aware, and I just wanted to thank Alyssa and thank him for that.
Yep. Anyone else have any comments, thoughts?
Is that date, the July 1st, 24, is that the original?
That's the date Chris and Allison asked us to put in. That the plan will be done, but they're going to give us all the updates beforehand.
The original date was January 124, and they asked us back 6 months.
Yeah, they asked us for 6 months. But that we're going to get quarterly updates starting this July, and so that we can see.
That means we won't be able to do anything then until the new session.
Well, it does say in the January 2024 progress update. So we'll have an update when we come back. We'll have an update July 1st. We'll have an update January when we're back. And in that update, they at least have to provide budget recommendations, preliminary budget recommendations based on what they've done so far, and a sustainable funding plan for the 988 Lifeline. So we're not exactly what we wanted, but we're trying to give them the time that they need, but still get something in January that we can work with. And I will say from my perspective, and I said this to a couple people in the room yesterday when we were off live, that just in talking about like next steps, we get this back in January, and if we find that for whatever reason it's not moving along, then we take action the way we feel is appropriate as a committee.
So just a question, it also says in there that we do Lifeline, 988 Lifeline funding. Do we have a idea, or is that to be set later? Or?
So the idea is for them to come back. So right now it's funded partly through federal grants and state money, but we're going to be losing the federal money.
Okay.
So come back with a proposal on how we're going to fund this thing, because
Process question. So I thought that when we're not in session, we're not allowed to receive reports. They go to the chair, but maybe that was left over from the previous chair. I was a little confused about that.
No, you can.
We're allowed.
Yeah, goes to the House committee.
We can even have special meetings.
It could, if we have approval.
Yeah, but we can.
Yeah, okay.
There are other quarterly reports that come in. I think there's a Medicaid one that comes in quarterly.
There's a couple.
So that's legit. Okay.
Yes.
Got it.
If there's no further questions, I'm willing to make a motion.
Okay, hold on. I just.
Yeah. I'm not trying to rush, sorry.
A moment. Oh, I didn't fill that one out for you. I'm
This is
sorry. Committee bill.
It's a committee bill, so what would it be called?
It's DR 230979. And it would be on the calendar for introduction first before
Right.
second and third reading.
Does it have a title though?
Oh, the act, yeah, an act relating to public health initiatives to address death by suicide.
It's line 6 on the bill for your visual.
Was there a motion and a second?
No, I'm
There
waiting.
is a
Oh,
motion.
I want to give Topper time and people time.
Yeah,
I just want to make sure one thing.
Yep.
They're gonna set up the school protocols prior to the plan being written.
This,
Isn't that the way it is?
yes, so the way it's written right now, the school protocol, the model protocol shall be developed and submitted January 15th, 2024.
Right. And,
So we'll have that and then a progress report on the rest of it.
okay, so the plan that's gonna be done, is that not gonna include school protocols?
Yes, right, so we're basically saying do that, we want to see
But make
that.
sure it's in the plan.
Yes, exactly, yes,
All right.
yes.
Okay.
And then we'll have to, part of the reason for that for January 15th is we can only direct Department of Mental Health to establish the protocol in collaborating with Agency of Education. Department of Mental Health does not have the jurisdiction to force them to implement anything, so that would have to come back.
And the budget is set to.
Yeah.
They gotta make recommendation on the budget.
Right.
Okay. Good.
All right, Brian, you want to make a motion?
Yeah, I'd like to make a motion that we pass draft
4-2.
4.2 of draft request 23-0979, an act relating to, hold on, no, I can't.
Line 6.
An act relating to public health initiatives to address death by suicide.
Second?
Second.
Top for seconds.
Call roll. Representative Rebecca.
Yes.
Representative Chena.
Yes.
Representative Cordes. Representative Demar.
Yes.
Representative Farlise Rubio.
Yes.
Representative Goldman.
Yes.
Representative Peterson.
Yes.
Representative Black. Yes. Representative McFawn.
Yes.
Representative Hope.
Yes.
And we have passed that on a vote of 9-0.
I'd be willing to report it unless there was someone else who really wanted to do it, since I haven't done one yet this year. But if a new member like Alan wanted to, or Top.
I'm waiting for a short one.
Okay.
I will eventually, but a short one.
All right, Brian, it's yours.
Yeah, and I would actually defer to you, but I think you're doing the other one, right?
I'm more than happy
Yeah.
to,
Yeah, so,
because I was thinking, oh, how am I gonna fit this one into?
yeah, and I think it's appropriate considering my role,
Yeah,
my job to
absolutely.
do
I
this
think-
too, so I might, and it's short, so I might set the
Thanks.
stage with something
Perfect.
anecdotal and, okay.
Great.
But I think it's really good that it's not one person on the topic. It's
I
more
agree.
committee. Yeah.
However, I still would defer to you since
We are good. So thank you,
Okay.
Katie. very
How about
much.
Katie?
Have a great
Okay.
weekend.
Right.
Thank you. as well.
Just so I understand the process again. Martin was here. We did the straw poll. Then where does it go? Now what?
So Martin, their judiciary will vote H230 out today,
Okay.
and it will be on the calendar next week for action.
And then, so and then you report, then they report.
Yeah, so it's
And
it's
then we
like a
respond.
typical amendment. So it'll be the House Healthcare Committee will report. Alyssa will be the reporter, and then the amendment from judiciary, and then Martin, I believe, is the reporter. And then there will be a vote to accept the amendment to the healthcare bill, and then there will be a vote on the whole thing. And so that would probably be on the calendar Wednesday for second reading.
Great.
This bill will have to sit a day because it's a committee bill, so it'll be introduced on Tuesday, be on notice on Wednesday, it'll be ready for action on Thursday. Your bill will be, psychology compact will be going through the process, so it'll be a little while. And 414, I will find out where it's gonna go.
Yeah, likely, well, maybe nowhere, who knows, but it'll be on notice anyway Tuesday.
It'll be on notice Tuesday, potentially up for action on Wednesday if it doesn't get sent to a money committee.
I gotta be prepared by Wednesday.
Yes,
But it is
yes, Daisy.
it is good to note that, and I don't know if the speaker might want to warn the body that Wednesday, Thursday, Friday, we're
Yes.
going to be talking about suicide on the floor.
Yes, we are.
So, I mean, I just know what it did for us, and like, how is that going to affect 150 people?
Yes, that's a really good point.
Yeah.
And also just remember, before we go off air, it's going to be a long week.
Oh my God.
Next week in the afternoon, potentially some late nights, so please bring food, snacks, be prepared.
Weighted blankets.
And other than that, have a